All right, so welcome and good evening, everyone. My name is Apu, and I'm the Injury Prevention Officer here at Injury Matters. And I'm so excited to be facilitating this webinar today, which will be looking at neurological conditions and its impact on falls in older adults. The slides. Okay. So before we start, I wanted to acknowledge the traditional custodians of the land on which I am facilitating this webinar today, which is the Whadjuk Noongar land. So I'd like to pay respects to their elders, past and present, as well as their leaders emerging. Australia always was and always will be Aboriginal land. I would also like to know where you all are tuning in from today, so please use the chat box below and acknowledge the traditional custodians of the land you are tuning in from today. Before we start, I just want to go over some housekeeping points. Can everyone please double check that their microphones are muted? This will allow everyone to hear the presenter clearly. We'd also like to hear your questions, so please, we strongly encourage you to send through any questions that you have below in the Q&A box as well. We'll go through them at the end of the presentation. If you have more than one person in the room with you listening in today's webinar, we would appreciate it if you could please send us a quick private message via the chat tab to let us know how many people are listening in with you. Also, if you have any technical issues during the presentation, please write them in the chat box and we will do our best to help you. I have Joe helping me today. Also, this webinar is recording, so just FYI. So a bit about Injury Matters. We are for safer people and places. Injury Matters aims to prevent and reduce the impact of injury within the Western Australian community. We do this through advocating and providing education for injury prevention, as well as providing support for people who have been impacted by injury. Today's webinar is brought to you through our Stay on Your Feet program with the support of the Department of Health WA. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults on how to prevent falls in the community. This is done through the Move, Improve, Remove campaigns. Move your body, improve your health, and remove hazards. Before I welcome our speakers, I wanted to have a quick look at falls in WA. Each year, 1 in 3 people over the age of 65 experience a fall. This becomes 1 in 2 people over the age of 80. On average, a Western Australian dies from a fall every 26 hours, is admitted to hospital for falls-related injury every 19 minutes, and attends an emergency department as a result of a fall every 12 minutes. As you can see with the stats on your screen, falls are a serious public health concern in WA. Neurological conditions are recognised as a risk factor for falls. Some of the common conditions seen to increase the risk of a fall include stroke, Parkinson's disease, multiple sclerosis, dementia, and epilepsy. The physiological factors that accompany these conditions can increase this risk of falls in many different ways. Due to the negative impact associated with falls, it is important for practitioners such as yourselves working with individuals diagnosed with a neurological condition to recognize this increased risk for falls and be able to assess and implement appropriate interventions. So to keep this discussion going and to elaborate a bit further, I'd like to introduce our first guest speakers for today, Anita Rattray and Lisa Barry. Anita is an experienced clinician who specializes in neurological rehabilitation, including stroke and Parkinson's disease. Anita completed her postgrad qualifications in neurological rehabilitation at the University of Western Australia in 2016 and is currently working as senior physiotherapist within the Parkinson's disease clinic at Osborne Park Hospital. And Lisa is an experienced qualified occupational therapist, graduating from Curtin University in 2001. She has a career spanning over 16 years in both community and inpatient rehab and subacute care settings within the public health system. Working with people with Parkinson's and other movement disorders has been an area of interest and passion with over 6 years of experience working as a senior occupational therapist in the Parkinson's clinic at Osborne Park Hospital. So I'm going to hand it over to Lisa and Anita.
Wonderful. Thanks, Apu, for the introduction. And thanks to yourself and the Injury Matters team for giving us the opportunity to present again on this really important topic. We're really overwhelmed by the number of people that are tuning in today. So I think we're at over 100 people tuning in at the moment. So that's really impressive. And it's great for us to be able to share some information about this area that's we're so passionate about, and it's a really important clinical area. So just get my slides up here. Okay, yes, sir. Okay.
Yep, so just go, oh, sorry, Lisa, if you wanted to hide presenter view and then share presenter, do the presenter view again.
All right, okay.
It's a bit fiddly, that. Yep.
Is that looking okay there? Perfect. Yep. So these are the objectives that Anita and I are planning to cover this evening. We have a lot of content to cover, so we hope we won't have to skim over some slides, but we'll see how we go with the time frame. So we're hoping to increase your knowledge and understanding of common neurological conditions and the impact on falls risk. Increase knowledge and strategies for preventing fall in people with neurological conditions, and increasing knowledge, available resources to support clinical practice. So just starting out with some general statistics. So as Apu mentioned earlier, nearly 1 in 3 older Australians have experienced a fall in the past 12 months. And of that cohort, 1 in 5 required hospitalisation. Then the areas that Anita and I are going to be focusing on today in terms of falls are stroke and Parkinson's. So Anita will discuss the stroke implications, and I will do the second half looking at the Parkinson's and falls risks. So falls are one of the most common secondary complications after a stroke. Within the first week after an acute stroke, about 7% of people will have a fall. Between 25% and 37% will fall within the 6 months post-stroke. And longer term, over a year post-stroke, about 55 to 73% of people will experience a fall. And although it's a wide range, a recent systematic review reported that between 35 to 90% of people with Parkinson's fell at least once, with an average rate of 60.5%. And of note, recurrent falls accounted for nearly 40% of all falls. So falls are one of Australia's largest contributors of injuries requiring hospitalisation and a leading cause of injury deaths. So in 2017-18, falls accounted for over 40% of hospitalised injury cases and 40% of injury deaths. The main types of injuries that we tend to see with falls through ED presentations or hospital admissions are things like fractures, so most commonly fractured knock or fractures of the forearm or hand, soft tissue injuries, intracranial hemorrhages, so subdurals. Obviously with our older cohort with anticoagulation therapy, they're at increased risk of these types of things occurring. And of course, you've got all the flow-on complications from these falls injuries as well. So you've got hospital-acquired conditions, so delirium, pressure injuries, pneumonia, premature entry into residential aged care, and even death. So there's a lot of serious consequences for our older people when they do have a fall, even though it might seem quite simple in the initial presentation. So looking at morbidity and mortality in 2017, 2017 to 18, sorry, I'm trying to read the slide here, 58% of hospitalizations for unintentional falls and 95% of falls deaths. So the costs can be life-changing for the individual and their family and carer. So you've got increased care needs after the fall or hospital admission. And what we commonly see with our patients after they've had a fall is that negative cyclical impact of the fall. So having a fall leads to an increased risk of fear of further falls, which impacts their confidence, impacts their activities and engagement in, mobility. Their movement's restricted, which impacts in turn their confidence going out and about. That can lead to mood changes, isolation, and weakness from inactivity. So, and that, of course, which we know can be false risk factors in themselves. So the cycle sort of perpetuates. So it is a big, big issue. And of course, there's the monetary costs as well. So in WA in 2017, of the nearly 28,000 falls-related hospitalisations, it resulted in 172,000 annual bed days at an estimated cost of over $244 million. I'm now going to hand over to Anita, who's going to share her screen, who will present on our first condition this evening, stroke.
Thanks, Lisa. Just waiting for the slides to come up. Hello, everyone. My name's Anita Rattray. I'm a physio at Osborne Park Hospital, and I'm going to be talking about stroke. Just wait for the slides to come up.
Yep, we can see them.
Yep, fantastic. Thanks, Apu. Okay, we're going to start with some statistics with stroke. So more than 27,000 Australians experienced their first stroke in 2020, and more than 445,000 Australians live with the effects of stroke. Stroke kills more women than breast cancer and more men than prostate cancer. Australian statistics of incidence of stroke, so you have 80% of them are ischemic and then 20% are hemorrhage. So to start off with, just to give you a little bit of background in the research that's going on in this space, the Stroke Foundation has carrying out a clinical trial, a pilot project that's worth $8 million over the next 4 years, which is based in Melbourne. It involves the delivery of a rapid response medical service via a mobile stroke unit to patients in the community who are suspected of having had a stroke. Mobile stroke units are found in several cities around the world: Berlin, Norway, and Houston. There are only 2 in the Southern Hemisphere, so Argentina and Melbourne. New data from the International Stroke Foundation in 2021 confirms that the mobile stroke ambulances have an essential role to play in pre-hospital stroke care around the world. The study has shown for every 100 patients treated by the mobile stroke unit, 27 will have less disability and 11 more will be disability free compared to the conventional hospital pathways. Mobile stroke units treat 33% of patients within an hour of stroke, compared to 3% in conventional care. Some 97% of TPA eligible patients were treated on the mobile stroke unit, compared to 80% of those on the conventional hospital pathway. So I'm going to try and share this video with me. Bear with me, Apu, you might need to help. We'll see how we go. Okay, might be behind. It's behind it. Bear with me. Nope.
think videos are a bit tricky.
Okay.
We might just, I can always share that around with everyone as well later if it doesn't work.
Yep, that sounds good. I'll just try and get back to where I was. Okay. Sorry, I've just lost the PowerPoint.
Anita, do you want me to share it from my screen and then I'll know when you will need to turn slides?
I just need to bring it up again. Shouldn't have tried anything fancy, hey? Okay. Okay, can everyone see the screen again? The PowerPoint?
Yep, that's all good.
Great. There it is. Okay, how do I make that bigger? There we go. Okay, thanks for bearing with me, guys. Apu will share that video for you. Okay, so the types of stroke we're looking at, we're going to look at the Bamford stroke classifications. So this outlines the 4 main strokes that a patient may experience. So you have a total anterior circulation stroke, also known as a TAC. There are criteria for this. So with this one, it meets all 3 of the following. So unilateral weakness of the face, arm, and the leg. And then you've got harmonious hemianopia, as well as a hiable cerebral dysfunction. Then you have the partial anterior circulation stroke, also known as the PACS. 2 of the following meet the criteria. So unilateral weakness of the face, the arm, and the leg, as well as a harmonious hemianopia and the higher cerebral dysfunction. With the Lacunar Stroke or the LACS, it must meet one of the following. So there's 4 different types of lacunas. So you have your pure sensory stroke, your pure motory stroke, your sensory motor stroke, and your ataxic hemiparalysis. And finally, you have your POX, or the posterior circulation syndrome, where it meets one of the criteria. So the cranial nerve palsy and contralateral motor sensory deficit, the bilateral motor sensory and motor deficit, conjugate eye movement disorder, also known as gaze palsy, cerebellar dysfunction, as well as isolated harmonious hemianopia or cortical blindness. So they're the 4 main stroke classifications. So being able to identify this with the patient is quite important because it makes you're able to understand what's actually going on with the patient. A brief look at neuroanatomy. So obviously understanding what kind of stroke they had, but also obviously identifies where they've actually had the stroke. So looking at the red portion of the brain there, the frontal part, that's obviously the frontal lobe. So that has to do with executive functions, so the planning, the concentration, the judgment, the inhibition, and as well as the personality. Just behind that, deep in there, you've got the Broca's area, just behind the frontal lobe. Then just behind the frontal lobe at the top there, you have the parietal lobe. And this has a lot to do with the sensory motor planning, spatial recognition, stereognosis, which is the differentiating between objects. Further down there on the lateral side of the brain, you can see the green area, which is the temporal lobe, and that has a lot to do with auditory as well as memory. You have right at the back there, being the grey area, you can see is the occipital lobe, and that has a lot to do with the visual processing and also the interpretation. So stroke deficits, there's a number of them. So the things to be aware of, you have your sensory motor impairments, your gait and balance disturbances, your cognitive and perceptual impairments, your visual deficits, as well as your communication difficulties. So each neurological patient has unique falls risk factors, which are disease specific. So looking at subjective assessment, it needs to be comprehensive and it needs to be goal orientated. This is what's actually going to develop your hypothesis as to what is causing the patient to fall. This is what drives your objective and actually drives what you're actually going to test to find out what's actually causing the patient to fall. You need to consider the history of presenting condition as well as the past medical history. You need to consider the recent falls history in the past 12 months. So here you might be thinking, it could be medical, it could be mechanical. So medical, you're kind of thinking syncope or loss of consciousness, or maybe due to an acute illness, versus mechanical, which is more about looking at your intrinsic, which is your age, your poor gait, balance, fear of falling, versus your extrinsic factors. So they're the complex environments and the medications. So always thinking medical, mechanical, it could even be both. So you need to be addressing both of those. Considering the home environment, really important. What's their access like? Do they have steps? Is there rails in place in the bathroom and the toilet? What's their shower and toilet setup like? Then you have the medications. So stroke patients are very commonly on anticoagulants and antiplatelet therapy, and we need to remember that this is a risk of subdural hemorrhage. Also, a lot of stroke patients for central post-stroke pain, you'll find they're on the gabapentin or the pregabalin, and that's obviously a cause of risk of falling as well. So always considering those medications. When it comes to also continence, so thinking about that, podiatry, orthotist, vision, auditory, vestibular, that's always something you want to clear, making sure that there's no kind of peripheral kind of stuff going on there. And cognition, so you want to screen for functional cognition, so looking at their memory, their concentration, their attention, and their organizational skills. Screening tools that are really important and helpful are the fear of falling, so maybe the falls efficacy scale. And for depression, you've got the geriatric depression scale. So once you've done the subjective, then you kind of got it, you developed a little bit of a hypothesis as to what might be going on with the patient. And this is what's now going to drive what you're actually going to test and find out exactly what you need to target in your intervention. So you need to be looking at motor control. So typically motor control with stroke, we look at using the Gowland, we look at using Fugel-Meyer assessment. You need to be looking at the sensation, the proprioception, and the joint range of movement. With the sensation, typically light touch and pinprick. You need to be looking at their balance. So whether it's Berg balance or a high mat assessment, whatever you feel is appropriate for that patient at the time. Looking at tone, so gold standard measure, as we know, is TARDIO. So measuring spasticity via the TARDIO assessment. We've also got looking at exercise endurance, so the 6-minute walk test. If they can't do the 6-minute, do a 2-minute. Start with something like that and see how they are. Looking at coordination. So here you're looking at the Cerebellar Testing. You've got your OT neurophysical. So this involves looking at the vision, the perception, the line bisection test for neglect. And then you've got your gait analysis as well. And the video is taking videos of gait is very helpful in your analysis, and I'd recommend that. Just with regards to the perceptual assessment, 4-point pusher scale is what we use at Osborne Park for pusher syndrome, which is really helpful. Okay, this is a really nice ICF model that kind of wraps it up all nicely. It's a framework specific to stroke, and it's a very helpful tool in identifying all of the contributing factors to falls post-stroke. So you can see down the bottom there, you've got your contextual factors. So your personal factors being the self-efficacy and the readiness to change. And then you've got your environmental factors, which is your home accessibility and the safety. And then on top of that, you've got all the bodily functions, activity limitations, participation restrictions, and that helps drive your interventions. Okay, so we're moving on to a little bit of research. So the Cochrane Review 2019 Interventions for Prevention of Falls Post-Stroke looked at 14 systematic reviews with a number of 1,358 participants were found to be investigated. They looked at different forms of exercise, pre-discharge home visits for hospitalised patients post-stroke. They looked at the provision of single lens distance glasses instead of the typical multifocal glasses the patient may already be wearing. They looked at an eye walker, robotic servo-assisted device, which is like a four-wheeled walker. And then they looked at the non-invasive brain stimulation. Currently, the key results state there's really little evidence for interventions other than exercise, which are beneficial for preventing falls post-stroke. There is insufficient evidence about the impact of discharge home visits, provision of single lens glasses, the robotic eye walker, or the non-invasive brain stimulation as an intervention for falls post-stroke. Moving on to Yang, a study that was done in 2021, looked at interventions for preventing falls in people post-stroke. This involved 13 random controlled trials involving a number of 1,352 participants. This was with one intervention versus a control group were identified. Stroke survivors were aged 51 to 76 were included. Interventions included things from treadmill, home exercise program, virtual reality, foot drop electrical stimulators, exercise with whole body vibration, perturbation-based balance training, dual task training, and Tai Chi. And it was looked over 6 weeks to 12 months. The key results, as you can see there, dual task training appeared to be the most promising intervention in reducing falls post-stroke. However, further research is required due to the small number size. In conclusion, results indicate that there's currently no program that is effective in reducing falls in this population at this time. So we're going to look at the Stroke Foundation clinical guidelines, which is always an excellent reference for when you're treating a patient post-stroke. So evidence for effective interventions prevent stroke in stroke survivors is limited. Stroke Foundation clinical guidelines recommend that stroke survivors at higher risk of falling require assessment of falls to identify the specific underlying causes of the falls. Problems that are stroke specific require targeted interventions. So for example, if the patient had difficulty with sit to stand, then that would be something that you'd be doing with them. You need to be looking at the fear of falling, the visual impairment, the cognition, the emotional and the physical factors should also be considered. Comprehensive home assessment to reduce fall hazards. So it's really important. It's not just one thing that we do with the patient. We actually need to be looking at their home setup as well, having a look at how they function in the home, and whether or not they need any modifications done to the home to enable them to move around safely, such as ramps, rails, over toilet frames. Okay, so looking at falls prevention and interventions in the older adult living in the community. So Sherrington in 2020 did an update from a 2019 Cochrane review. It involved a systematic review involving 64 random controlled trials. It targeted exercise programs showed to reduce the rate of falls in older adults living in the community by about 25%. Rate of falls compared with controls was reduced by 24% in balance and functional reviews, 23% in Tai Chi, 28% in multimodal programs involving the balance, the functional exercise, as well as the resistance training. So the multiple component group-based exercise also found to reduce the rate of falls. So this is probably one of the latest research that's going on in Sydney and Canberra. It's called the FAST trial. So FAST being Falls After Stroke trial. It's a 3-year random controlled trial and it involves a number of 370 participants. It involves stroke survivors less than 5 years post their first stroke. They are aged over 65 years, living in the community, and they can walk 10 meters with or without an aid. And they either get the intervention or they get the control group where they're not doing anything. So their program is a lifestyle integrated functional exercise program, community mobility and safety training. And the results are expected in 2024. Just to give you a little bit more information, so the Lifestyle Integrated Functional Exercise Program, it's about aims to establish the effectiveness of a home-based tailored intervention, so habit-forming exercise, community mobility and safety training. So for example, I think it's standing on one leg by brushing your teeth. So they're trying to incorporate all of the exercises into daily activities to help with compliance of doing the program. It hopes to reduce falls post-stroke, therefore potentially reduce the economy and the social burden that results from the consequences of falling. Okay, so we're now going to look at the disease-specific strategies for falls prevention post-stroke. This is taken from the Living Stroke Clinical Guidelines. So we're looking at the sensory motor impairment. So for this, we really want to be progressing resistance training. We want to be doing sensory specific training. For gait and balance disturbances, we want to be doing gait retraining, overground practice, treadmill training with or without body weight support, sitting, standing balance, practicing activities that challenge the balance, involving reaching outside of base support with supervision. For cognitive and perceptual impairments, attention and concentration deficits, so you're looking at cognitive rehab, unilateral neglect, so you've got your visual scannal training, your mental practice, your mirror box therapy. For the visual deficits, it tells us that all stroke survivors should be examined for visual acuity and visual field deficits such as hemianopia. However, insufficient evidence for these strategies for the visual dysfunction. Communication difficulties, all stroke survivors should be screened for communication difficulties and receive formal comprehensive assessment by a specialist clinician such as a speech therapist. Speech and language therapy to improve functional communication is highly recommended. So, take-home message. It needs to be, if you're treating a stroke patient in the preventing falls, it really needs to be a comprehensive assessment, and you really need to be thinking outside the square, having a look at everything with regards to their stroke deficits, but also thinking about referring on to other disciplines to make sure you target all areas of their falls risk. Community stroke survivors require the multidimensional falls prevention approach. So that's what I was just mentioning. Always refer to the stroke clinical guidelines for management of the disease-specific risk factors. Ensure your sufficient training volume and intensity in your interventions. Always consider extrinsic causes of falls, as well as the environmental hazards in the home, such as the home setup. Liaise with the GP if there's concerns about medications contributing to their falls. And always refer on to relevant healthcare professionals. Make it multi-disc approach. Okay, thank you. And I'll hand over to Lisa.
Thank you, Anita. I'll just get my screen. Oh, I have to wait for you to stop sharing yours, Anita. Okay, perfect. Thank you. All right, where are we? This one. Okay, because everyone see that okay? I'm just going to have to progress my slides.
Sorry, we can see your notes, Lisa.
Oh, okay. Don't want to see that. Just bear with me. Oh, okay, let me go back to my other one. Okay, what about if I stop, hide and show? How is that? Is that any better? You can still see my?
I can't see your slides. You're not sharing, I don't think.
Okay. going on here?
Yep.
Right, is that looking good? Or you
Yep.
can see my note. Yep, that's okay.
That's
Great. Okay, now I'm going to have to move the slides. Sorry guys, this is the first time that Anita and I have done a Zoom presentation, so now it's not progressing the slides. Don't know if there's a lag. Let's try again. I've got a lot of PowerPoint windows open and I'm thinking that might be an issue. So I'm just going to open it up again and try. Right. Sorry. Oh, okay, just going back to the beginning. All right, I'm going to have to go through this way. We'll get there eventually. I need to be stuck on the one slide, weirdly. Yes. I'm just going to do it just the normal slideshow, not the.
Yeah, if you have.
Yeah, and I'll do it with my, yeah,
Yeah.
I think that might work. Okay. So moving on to the second neurological condition of this evening, Parkinson's. So Parkinson's affects 100,000 people, out of 100,000 people, 38 people, no, let me start again. It affects 100,000 people in Australia and 38 people are diagnosed every day in Australia with Parkinson's. It's often considered to be an age-related condition as the prevalence increases threefold once a person's over 65 years of age. And it's the second most common neurological condition after dementia. So Parkinson's is caused, the pathology is by a loss of the dopamine producing cells in the substantia nigra, which is located in the basal ganglia, which itself is buried deep inside the midbrain, the base of the forebrain and the top section of the midbrain. So dopamine is the neurotransmitter involved in coordinating smooth sequential movements. The main signs of Parkinson's are bradykinesia, so the slow movement, tremor, rigidity, and postural instability. So in terms of diagnosis of Parkinson's, it's based on clinical signs and exclusion of other conditions. So when someone's seeking a diagnosis of Parkinson's, the doctor may do some imaging such as MRI or CT to exclude other conditions. There are also some cardiac innervation scans that they can do called MIBG scans, which will also give some more clues as to whether it's a Parkinson's, a true Parkinson's or a Parkinson's-like condition. Also, a positive response to levodopa, if they do a levodopa medication trial, can also point to being a Parkinson's rather than a Parkinson's plus condition. At the moment, we don't know what causes Parkinson's. We know that some people do have a genetic tendency to develop Parkinson's. There have been some genes that have been identified in causing Parkinson's, but there are a lot of theories out there as to what the etiology is. So there could be genetic factors, as I mentioned, environmental triggers. So doctors will often ask patients about whether they've been exposed to pesticides in the past or other sort of chemicals in the environment, as they think that that may be a trigger for Parkinson's. Head trauma, that's another possible theory. So there's lots of research going on worldwide as to what might be causing it. So unfortunately, there's no cure for Parkinson's at the moment, despite extensive research. Treatment is based on symptom management. So the gold standard for medication is the use of dopamine replacement therapy, so levodopa, which people might know as Matapar, Sinemet, Stalevo, they're the types of drugs. And there are use of other agents as well. So dopamine agonists, which act like dopamine in the brain, and other medications that might block chemicals that break down the dopamine or make it more readily available to be taken up in the brain. For some people, surgery is an option. So a lot of people may have heard of deep brain stimulation. So the implantment of electrodes into certain parts of the basal ganglia, and they insert a device that can be fine-tuned. It's amazing what they're doing with technology now, that they can make all these very fine adjustments remotely, I believe now. So it's a very exciting area. There is some evidence and a growing body of evidence to show that exercise has a neuroprotective effect, particularly early on in the disease process. It's important, of course, to treat the non-motor symptoms as well as the motor symptoms. And for most people, multidisciplinary input is very much required. Okay, so this is a really nice slide which shows the difference between the false risk factors for our older, or for any population really, but then looking at the specific Parkinson's related risk factors as well. So in knowing that Parkinson's is an age-related condition in a lot of cases, you look at the generic list there, and then a lot of people may have, a multitude of those sort of risk factors. On top of that, they've got the Parkinson's related risk factors. So issues like the cognitive impairment, the dyskinesia, so that's the excessive movement, freezing of gait and fascination, which I'll go into in further slides, the postural instability, the slow mobility, they all can combine with age-related factors to put them at an increased risk of fall. And the little stat down the bottom there, 60% of people with Parkinson's report at least one fall, and recurrent fallers report between 4 and 67 falls a year. And that's not an overestimation. Anita and I have probably seen many a patient that has had multiple falls to that sort of extent. We also, in the Parkinson's clinic, we look at some of the atypical Parkinson's syndromes as well, and they all have their own unique risk factors for falling as well. So progressive supranuclear palsy, or PSP, is one of those. So that's a primary tauopathy. It's a rare brain disorder that causes problems with movement, walking, balance, and eye movement. And it results from damage to nerve cells in the brain that control thinking and body movement. The disorder's long name indicates that the disease worsens, so progressive, causes weakness, palsy, by damaging certain parts of the brain above nerve cell clusters called nuclei, so supranuclear, that control eye movements. The hallmark of PSP is the accumulation of abnormal deposits of the protein tau in nerve cells in the brain. So the deposits cause the cells to malfunction and die, which stops the flow of information getting to the other cells and nerve cells. PSP is usually sporadic, meaning that it occurs infrequently and without a known cause. People with PSP often have early falls, and typically they tend to go backwards as well. So that does make it a little bit unique. There are changes, of course, to their eye movements as well, and their vision. So they can experience any number of these things. So blurry vision, difficulty shifting their gaze, particularly up and down. So that makes it difficult when, approaching uneven surfaces, steps and those types of things can pose an extra risk. They do have axial rigidity, which can lead to gait impairment. They sort of can be quite rigid through the neck and upper back. And also some of the non-motor symptoms as well, so the impulsivity, reduced insight, poor problem solving and cognitive impairment all make it extra, tricky for them in terms of falls. The other condition I just wanted to mention was multiple systems atrophy, or MSA. We do see a fair bit of this through the Parkinson's clinic as well. So this is also a progressive neurodegenerative disorder, but it's characterised by a combination of symptoms that affect both the autonomic nervous system and movement. So the symptoms reflect the progressive loss of function and death in different types of nerve cells in the brain and spinal cord. It's much rarer than Parkinson's. It's about 1 in 10,000 people, and it's about 2 to 3 times more common in women than men, which I don't know if there's my anecdotal experience of that, but that's interesting. There are different subtypes as well. So you've got MSAP, which is more the Parkinson subtype, MSAC, which is more the cerebellar type, which you see the ataxic gait, visual changes, and some of the swallowing and speech problems, and then MSAA, which is more the autonomic dysfunction. People with MSA typically have similar motor symptoms to those with Parkinson's, such as poor balance, rigidity, and slow movement. They also can show incoordination with movements as well. They'll often exhibit changes with their posture, including their trunk and head flexion, which you can see in the slide at the bottom, and some postural asymmetry. If the postural changes are sort of noticed early or really more severe, if someone's coming in with a Parkinsonism, it can be a bit of a red flag for MSA. So it might be hinting that it's going to look more like an MSA than a Parkinsonism or a Parkinson's disease. So in more of the advanced stages, you might see people with these postural impairments that you can see at the bottom of the slide, so the head drop or the extreme trunk flexion. So, I mean, mostly when people get to that stage, they may not be ambulant, but of course, if you can imagine, if you've got this sort of flexed or and semi sort of fixed posture like that, it's going to have implications for staying on your feet safely. Of course, the autonomic dysfunction as well is an extra risk factor, so changes with postural hypertension, so getting up quickly and feeling dizzy. Also the urinary frequency can lead to falls, and people have got that urgency and are rushing to the toilet. That could lead them to having a fall. So I spoke about the anticolate head drop and the cantocornea, which is that very much that extreme trunk flexion. I just want to quickly touch on this one, which is the Hoehn and Yahr staging of Parkinson's disease. So it shows just the progression, and most doctors and nurses will use this to describe the symptoms they're seeing in the patient. So stage 1 is early on the disease process, there's just involvement in one side, and functionally they're not having too much of an issue. Stage 2 symptoms start to become bilateral. They may or may not have impairment of balance. Stage 3, bilateral disease. So you start to see people really struggling with their function. They still can be quite independent, but are starting to have some issues. Stage 4, severely disabled, still able to walk or stand unassisted. And stage 5 is bed or chair bound. So subjective assessment. Now, Parkinson's is a really complex and multifaceted disease. So going along with that, you would expect that your assessment would also be pretty involved. So basically all these areas we would tend to have a look at when we have a new patient in the clinic or a patient that's being re-referred to us. So it's of course comprehensive and goal oriented, so client-centered approach, all the usual things like what they're being referred to you for and what their previous medical history, other comorbidities may be. Looking at their recent falls history in the last 12 months. So, and again, as Anita mentioned with the stroke, looking at the medical versus mechanical falls. What were the risk factors or the risks behind those falls? Fracture risk, so looking at their calcium and vitamin D intake, have they had a bone density scan, they've got osteoporosis, so looking at that. Home environment, which I'll go into a little bit more detail later on. Continence, their medication, so what doses are they on, how frequently do they take them, and what are they actually taking, and what's their compliance with taking them as well. reviewing specialist letters to see any changes that may have occurred recently, movement difficulties. So again, I'll go into that in more detail, what all those movement difficulties we might typically see. Do they regularly see a podiatrist, or they have any orthotics that might impact their gait or their balance, vision and auditory changes, level of ability, so in their basic ADL, so they're showering, dressing, toileting, medication management, and the instrumental ADL, so can they cook for themselves, who's doing the cleaning, do they do gardening, do they drive, who manages their finances, all those types of things. What kind of supports do they have if they need them? Cognition and visual perception, and as Anita mentioned before as well, looking at some other screening tools if that was indicated, so fear of falling scales and geriatric depression scale. And then objectives, so looking at balance. So again, in the Parkinson's clinic, the physios will quite often do the Berg balance, a timed up and go as well. So that might be just a standard around the chair time up and go. There might be a dual tasked one, which is looking at integrating a cognitive component into that as well. I threw in there the PKG, the Parkinson's Kinetograph. That is something that can give us a little bit of information about their on and off times, whether they're impacted by tremor, whether they're slowing down at certain parts of the day. So it's a watch that people wear on their wrist for a period of time that does a monitoring of their different movement patterns. And there's a printout that you can generate a report to look at, like when they're taking their medication and when they might be having slowing down periods, when they might be having dyskinesia. So it gives you a bit of an idea of what's happening throughout their day, particularly if they're not a very good historian. It can give you some more objective information. Muscle testing, gait analysis, looking at their exercise endurance, looking at other issues with postural drop. Levodopa can exacerbate that, so sometimes that is an issue for our population, and we usually liaise with nursing staff about that. And cognition, so really important to look at cognition, because we know how closely that links with falls risk. So looking at using maybe a mocker to get an objective measure, and then looking at functional cognition as well, their executive function, visuospatial, their attention span, can they carry over information, are they taking things on board, what's their insight like, so getting some more information there. So a little bit of research, just a couple of things. So there was a meta-analysis done back, this is a little bit old now, 2016. So they did 5 short-term studies and looked at 6 long-term studies and determined that benefits are observed immediately after doing exercise with regards to falls prevention immediately after and at follow-up, which I'm not sure that follow-up period was. And the PD SAFE, it's a multi-dimensional, individualised home-based program that was delivered by some physiotherapists. And evidence has shown that while targeting single risk factors for falls may not affect the person with Parkinson's overall falls rate, when it's combined with behavioural and strategy training in a functional, personalised, multi-dimensional model, there's a greater impact on falls reduction. So it sort of makes the conclusion that falls intervention in people with Parkinson's should be multi-dimensional. And that's certainly the approach that we take at Osborne Park Hospital. So moving on to some specific falls prevention strategies and interventions for the Parkinson's population. So specific exercise for people who experience balance or motor function problems. Balance and gait have been shown to improve with exercise, thus reducing risk of falling. Sounds very common sense. And exercise is shown to be beneficial in people with Parkinson's, including aerobic exercise, such as dancing, treadmill training, resistance training, Tai Chi and yoga, and high intensity training may also improve motor symptoms. Okay, so another important thing is looking at walking aid prescription. So using the Berg balance scale to help in guiding that assessment process, the physios will have a look at the score that they got on their Berg. Sometimes for PSP, because of their propensity to go backwards, there may be weight added to the basket of the forward walker, or you can actually buy quite reinforced sort of weighted walkers as well, which can give people some more stability. Turning strategies are really important. We look at this in their clinic appointments at the hospital and really look at reinforcing this in the home context as well. So that's where OT might have a look at the particular places in the home where turning might be an issue, and really look at putting some strategies in to, to generalize what they've learned in the clinic into their home context. Liaising with specialists, of course, if there are concerns about motor fluctuations and we think, oh gosh, they're really dyskinetic, their balance is really impaired because they're moving all over the place. We would sort of, liaise with the medical team or the nursing team as well about perhaps looking at the medications if things are a little bit off there. Referring to an orthotist for management of foot dystonia. So that's the abnormal positioning or cramping of the foot, which can cause obviously balance problems and can be very painful too. Refer to optometry for visual aids if there's a gaze palsy. A little bit of evidence about that, but not a lot. Some other things. This is probably one of our main areas, is looking at the strategies for managing, particularly in the more advanced stages, the festination, so those very small shuffly steps that get progressively smaller. Quite often you'll see people with their bodies coming forward, their feet are kind of left behind, can really increase their risk of falling. And of course the freezing of gait as well. So when they maybe moving through a crowded place or a doorway, really having difficulty with maintaining their gait, speed and stride length to the point where they may actually get completely stuck on the spot. So looking at things like auditory cues, so looking at getting them to try and internalize some things like left, right, 1, 2, step now, big steps, large steps, long steps, whatever works for them. Sometimes people don't respond to that internal cueing and they'll need someone to do that for them. So it might be upskilling the carer or the partner to be able to cue them through that. Which is obviously tricky if they're still going out and about and doing things on their own. So that's where we really try and empower them to learn what works for them, so that they get in a tricky situation, they can easily recruit some strategies to try and improve their gait. Visual cues as well. You'll see a few things on the right-hand side of the slide there with some lines and taping. I'll look at taping in a few slides down the track, but visual cues can be a really strong thing for people with Parkinson's to use to break up the freezing and also to manage their stride length. So it might be things like pieces of tape on the floor in their home. It might be about teaching people to step over a grout line when they're at the shops. And then you have things like laser walkers that you'll see, the U-step walker there, or you can even get little laser projectors from belts or on your shoe, walking sticks. So it just projects a little line in front of the person that they can step over. So things like that. So I think I've talked about a few of those. So yep. So functional movement strategies, telling them to stop sounds counterintuitive, but people panic and keep sort of moving forward with their upper body. So getting to stop with their heels back on the floor, then recruit their strategy. It might be rocking or weight shift from side to side to get things happening. And also relaxation is so important. People get really stressed out when they freeze, which you can understand, particularly if you're in a busy place, but actually, feeds into that negative loop that, they sort of get stressed, which makes their symptoms exacerbate. So teaching them to take a few deep breaths and to really rely on their strategies. Okay. So falls management, of course, people may, they will still fall. So looking at falls management, so teaching them what to do if they do have a fall at home or out and about, how to assess whether they're injured, how to get up off the floor safely, management plans for carers as well, so they're not manual handling or hoiking someone up off the floor and injuring themselves too. And then looking at providing some information about personal alarms, fall detection devices, or getting them to refer through to my aged care for a subsidised alarm if that's appropriate. Of course, looking at strategies to reduce the falls risk, so avoiding dual tasking, so avoiding doing the two things at once. Quite often it's the balance that is first to go, I guess, when people are doing two things at once. They'll always focus on the cognitive task, or the carrying the cup of tea into the dining area or something rather than their balance. So just going through those areas where they may be having more falls and are doing two things at once. So education about sitting down to put pants on, sitting at the dining table to prep their veggies rather than standing in the kitchen, using a crossbody bag to carry items, using a kitchen trolley, those type of things. Of course, footwear is really important too. So we reiterate that a lot about supportive, well-fitting footwear, and non-motor symptoms. So a huge thing for people with Parkinson's. And all of these things are areas that we would look at. So I mentioned the postural hypertension before, so that can be medication related or people with multi-systems atrophy or other comorbidities. So teaching them about taking their time, avoiding sudden changes in movement, keeping hydrated, and of course referring back to their specialist or treating team if we think it's an issue that needs addressing. Looking at fatigue and sleep disturbance, so sleep hygiene, getting them to optimize their sleep and looking at activity balancing. And then the cognitive side of things as well. So teaching them cues to manage complex activities, and teaching the carer as well if cognition is a considerable issue, looking at cue cards to prompt them, and also, as I mentioned before, that anxiety management as well, to reduce their frustration. And then in the home, so looking at the falls risk factors and recommendations. So I mentioned before about reinforcing those mobility strategies in the home. So that might involve just lots of practice of clock turns. So particularly in the small areas like toilets, walk-in robes, walk-in pantries, turning away from the fridge or the sink in the kitchen, or the arc turns approaching a chair or a bed if there's enough space to do so, and avoiding the dual tasking. Avoiding clutter. This is a big one for a lot of the homes that I go into, and not just talking about physical clutter, but also visual clutter. So if there's lots of stuff going on in the rooms, lots of throw pillows and lots of art and books and things like that, that can really trigger people's freezing and fascination. So we try to encourage people, particularly for the walkways, to be clear, minimize clutter as much as possible. Of course, trip hazards, so rugs, people are very protective of their rugs. So that is a tricky one for us to try and challenge, but at least taping down the edges or getting rid of the very light, small mats that people might have at their front or back door, cords as well, and highly patterned surfaces can be a trigger for freezing as well. So like highly patterned carpets and things or rugs can be a problem for some people. Looking at nighttime toileting, so as OTs we would look at this. Also the nurses would have a look at this too, and the physios if they're going into the home. So looking at their bed mobility, what kind of lighting do they have at night? Do they turn the light on? A lot of people don't like to do that. They say the street light and illuminating through the window is quite adequate, but we know that adequate lighting is important for reducing falls risk. Nocturia and frequency overnight is a big problem for a lot of our people with Parkinson's. So again, referring back to their medical treating team or their GP to look at things like they need the involvement of continence management advisory service or a urology referral to look at why they're getting up 6, 7, 8 times a night to go to the toilet. Commodes and urinals to just avoid having to negotiate a dark house in the middle of the night, particularly if there is frequency or urgency. Equipment, so whatever they need, grab rails, non-slip surfaces, we provide recommendations about those things and equipment to make things safer for them. Access to the home, so this is often an area that people will have difficulty with, particularly if they've got something like a 4-wheeled walker. Getting that over a threshold step or managing steps. Interestingly, people with Parkinson's tend to do usually pretty well with steps. It's quite a nice visual cue, stepping up onto something, so long as they've got something solid to hang on to. Ramps, I don't love for people with Parkinson's. I have put them in for a few people, but with 4-wheel walkers, a very sort of low gradient, 1 in 20, but it actually can change people's center of gravity quite a bit. So it's not always the most appropriate piece of equipment or modification to put in. You know, you've got issues with people tripping over the upstands on the sides of the ramp. You've got impulsivity. People may not necessarily control their descent when they're going down the ramp. Of course, their centre of gravity is pitched forward. Or, you know, going down the ramp for people with PSP, it's going backwards. So yeah, use with caution, I would say, with ramps. So the alternatives you might want to look at for a ramp, and people do like to, and GPs like to suggest ramps. No offense to any GPs that might be tuning in, but sometimes things like a platform step or a half step might be more appropriate. Referring to the physio to practice the steps, it might be a confidence thing. Looking at magnetic latches to hold the door open, those kind of things are alternatives that could be looked into. Lighting and glare, as I mentioned before, making sure people are opening the curtains and getting enough light in, but also that it's not too bright and glary off white gloss cabinets and things like that. And along with the whole team, educating the patient about their medication as well. So looking at the phrase on time, every time is really important for Parkinson's medication. So all of us will be banging on about that to our patients. It's super important. Taping, yes. So I do get a lot of questions about taping. So I thought that might be useful for people tuning in to have a look. So as I mentioned before, really great visual cue. Doesn't matter if people step on, over the line, whatever works best for them. And the width of your tape strips or the distance apart is based on what their normal or preferred stride length would be. So, and their height sometimes will, you might have to just play around a little bit at their home and see what feels natural for them. Yep, stepping on the line or striding out over it depends on the patient. A contrast in colour, of course, is really important. So they can see it. Red or yellow is what we carry in our hoovering bags, and that seems to work well in most floor scenarios. We do minimum strips. People often want us to tape the entire corridor and every part of their house, but the novelty can wear off as a visual cue. So we tend to just use the minimum number of strips, maybe like 2 or 3 sometimes is enough just to initiate that movement, and highly problematic areas only. So trying to work with the patient to work out what is their sort of biggest risk area. And for a lot of people, it's toilets and turning into the bathroom. So it can be, yeah, as a prompt to initiate the movement. So a doorway, so clearing a threshold, or indicating a step up or the start of a turn. Or clock turn. So you see the toilet there with the 4 strips of tape in the sort of 12, 3, 6 and 9 formation to indicate them to march around in the clock turn direction. Okay, so I hope we're going okay for time here. I'll just quickly go through this case study. So this is based on a real patient that we saw through the clinic. It wasn't actually my patient, one of my colleagues. So Mr. G was a 79-year-old with idiopathic Parkinson's diagnosed 8 years ago, and he does have postural hypertension. So he was reporting frequent falls, accessing the toilet overnight. So he was going about 4 or 5 times a night. So his issues were really reduced stability with sit to stand from the bed, and combined with this postural hypertension that wasn't great. So what the OT did in this situation was move the bed a bit closer to the wall and put a grab rail on the wall opposite the side of the bed, which allowed for him to utilise that if he needed to for a sit to stand, and then use that to stabilise himself and get his balance and make sure he was feeling good before he moved off towards the bathroom. This particular chap also had difficulty with walking past the shower screen to get to his toilet in the ensuite, and was freezing there. So he was really worried about falling through the shower screen. We weren't sure whether it was because he couldn't see it very well, or whether it was just this anxiety that built up over time. So what was tried and worked really effectively for him was taping a few big X's in brightly coloured tape on the shower screen as a prompt that it was there. And that really helped him to know that that's how far away it was for him. He also then had difficulty reaching the toilet. So there was some taping that was done on the floor in an arc to turn towards the toilet. And so other things to consider in this scenario are, of course, lighting, making sure he had adequate lighting to get to the toilet and in the bathroom, and a continence review if appropriate. So you know, education about fluid intake. Was he drinking cups of tea before bed, or was he not drinking much fluid during the day? Looking at all those sorts of things and referring on as relevant. Checking his bed mobility. So if there were urgency issues and he was really slow getting in and out of bed, you know, that might need addressing further. And a urinal bottle as well. Was he happy to do that, not walk to the toilet and just take that out of the equation? So that was just a nice little case study to show some different sort of falls things that might occur. And then the last thing I just wanted to mention, I don't know if many people that are dialing in today are working on an inpatient ward, but just touching on that with Parkinson's. So I guess the important thing to do with patients on the ward that might present with Parkinson's is to look at the inpatient notes. So look at the falls data and try and work out where and when they're falling. If they're falling on the ward, trying to identify potential patterns and triggers. So have they had medication changes? Is that what they're in for? Are they in a shared room and getting really disturbed by their person that's sharing the room with them? Of course, we know in hospitals, most people will have poor sleep because new mattress, unfamiliar environment, that type of thing. Lots of noise overnight and lights and things. Deconditioning, if they're in there for another condition or have just been deconditioning at home. Are they disoriented, being in an unfamiliar environment? Are they using their call bell? Can they get to their call bell? And how long is it taking for their needs to be attended to? So those kind of things might just give you a bit of an idea if you can find them either from discussing with the patient or the team or in their file. And then this is just a nice little table of some different sort of strategies that you can utilise on the ward. So some of the risk factors might be the clutter and distraction. So if it's safe, minimising the signage in the room. I think we all know that ward rooms often have a lot of different things, whiteboards and different signs, hospital signage around. Streamline the furniture around the room and bed, make sure their walking aids are within in reach and their call bell, taping any excess cords away, and then consideration regarding the roommate in the shared room. So alarms going off, talking, if that's an option. So the freezing and the associated anxiety exacerbated by an unfamiliar environment. So sometimes we'll do taping on the ward to get into the ensuite or across the corridor, and making sure that the cues are consistent across the whole team as well, and noting it on their mobility chart. That's really important. So finding out what works for that particular patient, what's working in that environment, everyone doing the same thing. Looking at their unmet needs, so addressing the 4 Ps, so pain, position, personal needs and possessions. Medication changes, so obviously the team will be working really closely together to look at you know, dyskinesias, motor fluctuations and hallucinations if they're bumping up some of their meds. Deconditioning, so physio is really important, of course, and also any additional movement that's safe to do on the ward. So walking with the nursing staff and their home exercise program in their room, if they can do that safely and independently, or with their family coming in to help them do some extra repetition as well. And footwear, so supportive footwear, trying to send home with the family any slippers or scuffs they might bring in. And avoiding socks. Of course, a lot of hospitals will provide patients with the socks with the really good grip on the bottom, so they're fine. And ensure the shoes aren't creating a trip hazard. That's important too, so they're not right in front of the chair. Common sense stuff, yeah. So take home message. So Parkinson's, as I mentioned before, is multifaceted, so really needs obviously that multidimensional and MDT approach. Comprehensive assessment is really important. The NICE or NICE guidelines, and there's an OT best practice guideline from the UK as well that has some really good tips for managing those disease-specific falls risk factors, and of course referring on to relevant healthcare professionals. Thank you so much for everyone tuning in today.
Thank you so much, Lisa and Anita. That was a very interesting and very thorough presentation. I'm just mindful of time, so we'll just quickly go through. We have 2 representatives, one from Stroke Foundation, which is Luke Hayes, and the other from Parkinson's WA, which is Janet McLeod. So we'll hear from them about their resources and all of the programs that they provide to the WA community. We'll start with Luke Hayes. Luke Hayes is the State Manager of the Stroke Foundation WA. So over to you, Luke.
Thanks very much, Poppy, and thank you to both Lisa and particularly Anita for your presentations. They were great. I'll just share my screen now. you getting that okay? Great. Yeah, so as Apu mentioned, my name is Luke. I'm State Manager for WA and South Australia for Stroke Foundation, and I'm just here to talk briefly about what Stroke Foundation resources are available and what's new and what's coming up. I'd also like to really acknowledge the traditional custodians and elders of the lands on which we all live, which for me are, like many of us, the Whadjuk Noongar people. And we really reflect on the continuation of the cultural, spiritual and educational positions of First Nations people. So my talk, and I'll keep it fairly brief, is going to be looking at what resources are available from Stroke Foundation for survivors of stroke, their families and carers, for health professionals, and also for the broader community. So starting off for your patients, your stroke patients, one of our most important resources is Stroke Line, which is a free call number available anywhere in Australia during business hours, Monday to Friday. And those business hours are Eastern States business hours. So in WA, we're about 3 hours behind, obviously, at the moment. But the number for Stroke Line is on every My Stroke Journey pack, and I'll talk about My Stroke Journey a bit in a minute. And we have social workers like the amazing Siobhan here, speech pathologists, occupational therapists and nurses who are available to answer questions of stroke survivors, their families and carers, but also of health professionals as well. And we do get calls quite often from people working with stroke, critically with stroke survivors and stroke patients. And you're free to direct your patients to us. Some of our hospitals help stroke survivors and their families and put this number in their phone before they leave hospital. The other things that we've just started, and this is really off the back of what we've seen over East and what we're starting to see here in terms of COVID-19 response from health services everywhere, where services that are like elective surgery and particularly important for stroke patients, community rehabilitation and outpatients are being redirected to support COVID management within the hospitals. So what we've developed is free weekly interactive information and education webinars delivered by experienced Stroke Foundation clinicians that really aim to support stroke survivors, their families and carers in that initial phase in hospital or just after they've been discharged. Those are available, as I said, weekly. There's a process whereby you can register your patients or help them register, and that's available through the Stroke Foundation website, which I'll send around some information via Apu later. Enable Me, which many of you may have heard about, is an online platform for stroke survivors and their families and carers. It contains podcasts, videos, fact sheets, and a really active online stroke community. It can be accessed from anywhere, obviously, at any time, and we really encourage health professionals to introduce your patients to this resource to support stroke education, start early goal setting, and connect survivors with peers, which we all know is just such a powerful support for them. The main, we have a range of resources in Stroke Foundation, but the main one that we use for stroke survivors and patients is My Stroke Journey, and it comes in a suite now. So we say that, or we ask health professionals working with stroke patients, every patient, every time gets a copy of My Stroke Journey. So the primary resource is, of course, My Stroke Journey that you can see here on the screen. It comes in two flavours, classic and easy English, which of course is designed for patients who have, sorry, I'll just go back there. have a problem with communication. We've also developed and released last year our stroke journey, which has been designed with and for Aboriginal survivors of stroke, their families and carers. And then lastly, but not leastly, our family stroke journey, which is really aimed at families of young children who have experienced a stroke, because as you all know, stroke can affect anyone at any time across the age range. And just to add to some of Anita's statistics earlier, we're seeing, we would expect to see about 2,000 or over 2,700 Western Australians experience their first stroke this year. And there are almost 45,000 Western Australians living with stroke currently in the community. So those numbers give you some idea of the extent and incidence and prevalence of stroke. Some other key resources that we have developed for people are resources about stroke in other languages. And you can see there the 9 key languages that we've developed so far with stroke information. We also have set up a young stroke project. One of the things that is really concerning to see in the research that's coming through is that the numbers of younger working age people experiencing a stroke in Australia is increasing. And that's consistent with trends that we're seeing overseas as well. Some of the thinking around that is that we're starting potentially to see population impacts of more sedentary lifestyles, more poorer diets that we've become accustomed to, higher salt, high sugar, high fat. And those things cumulatively maybe now starting to have a visible impact on strokes in Australia, which is really concerning. So this project has been developed to deliver information tailored specifically for young people who have experienced a stroke, their families and caregivers. And we know that that information is very different to the information that's needed for older people. The project is really creating content and resources similar to the ones for the older population, but with different areas of focus that are reflective of the needs of working age people. So we really want to equip people to make informed choices to solve problems and access supports and services that are available for them, and empower people to advocate for themselves and access, navigate and influence the mainstream service system. We're making sure that younger survivors of stroke know about us at Stroke Foundation and how to connect with us and find what they need. And the resources that are being developed will be built on Stroke Foundation's existing platform of Enable Me. So at the moment, there's some really great stuff happening in co-design with younger stroke survivors around podcasts and videocasts and online services to support that community. The national, and this is moving on to clinicians, the national webinar series that's been developed and funded for clinicians working in stroke, which is an interactive peer-to-peer education for health professionals. The program addresses current practice gaps in stroke care and supports improved stroke care across Australia using Stroke Foundation's evidence-based resources. Don't forget to register for that, and you can see there an example of some of the very popular sessions that we've had just in February on sensory motor retraining with stroke survivors. It's been very popular. If you're interested in finding more information about that, it's on our website, and I'll include that information in the info that I send via through. The other thing that's really useful for clinicians is Inform Me, so that's our online platform. It contains our clinical guidelines, which are nationally endorsed, providing evidence-based recommendations for the management of stroke, and you would have heard Anita mention those earlier. It also contains learning and resources around acute management of stroke, discharge planning, managing complications, rehabilitation, secondary prevention, and stroke prevention. Those attract CPD points as well. It contains stroke data relating to the delivery of stroke care based on the stroke guidelines and quality care through your own hospital. And it aims to improve care with quality improvement plans and news about events for health professionals. Really strongly encourage you to have a look at Inform Me, especially the online e-learning packages, which are great for continuing professional development. If you don't know where to start, please drop me a line and I can help out with that. I'll include my contact details at the end of this presentation. So nationally, we also run clinical guidelines, as Anita mentioned earlier, but also the national audits. So we're currently in a 3-year pilot project to build and evaluate the world's first living guidelines for stroke management. As you could guess, that's a big project and we're really keen to see it continue. Basically, that means that no longer are we having to wait for, between 3 to 5 years to receive updates on our clinical guidelines, but these updates are being done within 3 to 6 months. So there's a process whereby all the existing evidence is scanned, sorted through, goes through to our National Clinical Council and the NHMRC for endorsement, and then gets uploaded into online guidelines so that they're much more, you can have more confidence that as a clinician, the information that you're looking at through those guidelines is up to date. The other thing that we do is around the clinical audits. They happen every year. 1 year they're on acute stroke services and the next they're on stroke rehabilitation. And they really provide hospitals a really good indication about where they're up to with their stroke care and where the gaps are, what they're doing well, and so on. This year, there will be a cut-down version of that stroke rehabilitation audit, and that's really reflecting and in response to the challenges that are being posed by COVID-19 in the health system. In the community, and I'll just quickly skim over this, one of the key ways that we raise awareness about stroke is through the FAST message. And what does FAST mean? Well, many of you will be already aware of this, of course, face, arms, speech and time. And we run programs educating the community around that. The other thing that we do is really work with our partners to develop reports. For example, you can see here the report on the economic impact of stroke. We also do regular updates on what we call No Postcode Untouched, which is looking at the prevalence and incidence of stroke both now and into the future. So keep an eye out for those. And if you have any questions or you'd like to just ask me anything about anything that I've talked about tonight, please don't hesitate to contact me on those details. Thank you.
Thank you, Luke. Sorry, I'm very mindful of time, so we'll just quickly go to Janet. Janet McLeod is a Parkinson's nurse specialist and a clinical nurse manager at Parkinson's WA. And is going to share some projects and resources that Parkinson's WA is working on. Sorry, Janet, you're on mute.
Right. Okay, is that better?
Yeah.
Yeah, thank you. Thank you so much to the organisers for asking me to present and to represent Parkinson's WA today. This looks like it's working smoothly, so Let's go. Okay, so it's always my pleasure to represent Parkinson's WA. Many of you may know me. I have been in the position for quite some time. So I am just going to give you a little overview of what we offer, a little bit about our background and how you can refer to us. So Parkinson's WA is a locally based organization, completely autonomous, though we are incorporated with Parkinson's Australia. In addition to the nursing service, we run a diverse lot of support mechanisms for people with Parkinson's. We have local support groups, both within the metropolitan area, scattered in different suburbs. Combined with those, we have several carers groups that meet informally in cafes and add support to the partners and carers of people with Parkinson's. We have some support groups in regional, rural areas, and those support groups are all run independently, but under the guidance of Parkinson's WA. The main core of our business is in WA. We produce most of the publications that are used nationally. We have brochures on driving, communication, medications to be used with caution, and a whole variety of publications which are updated on a very regular basis. And I am very aware of that because I'm the one who does them. So when you read them, you can perhaps relate to the accent. We do try to keep them updated regularly, particularly the things like driving. We do offer seminars, and in a normal environment, we would have 4 to 6 seminars a year. 2 newly diagnosed seminars are run every year. Obviously, for the last 2 years with COVID, we've been quite challenged by those. We do have a newly diagnosed seminar with great optimism booked for April, but I'm in the process of planning how to turn it into a webinar. In the last 18 months, we've introduced a counselling service, which is available to people with Parkinson's and partners and family members. And this has been a great initiative. There is a small charge, $20, which includes GST, which is payable, but it really has been a major breakthrough for our cohort, and also a great toolbox for the nursing team to have to be able to refer to our counsellor. Because the battle cry of people with Parkinson's when looking for someone to talk to about their condition is always, do they know what I'm experiencing? So having a counsellor who's been with us now for 2 years and is very competent with Parkinson's has been wonderful. I would encourage you to join Parkinson's WA. We would like you to pay the annual membership fee, but as health professionals, membership is free. And the more numbers we have within the organisation, the greater our voice is when we're lobbying with the government for funding and other such things. So my main challenge in life and passion in life is the Parkinson's Nurse Specialist Service. So that's what I'm going to concentrate on today. The Parkinson's Nurse Specialist Service has been in action since 1998, when a small group of people with Parkinson's lobbied the state government for funding to run a trial of one nurse for the metropolitan area for 1 year. And I was fortunate enough to be given that position, and we've now been running almost 24 years, and we have a total nursing team of myself plus 7 nurses out in the field. It's in part funded by WA Health. Funding is always an issue, but a lot of the funding also comes from Parkinson's WA. We service the metropolitan area, and we also have 2 nursing positions based in Bunbury, which look after some regions in the southwest. Albany and Geraldton are very well looked after by the Neuro Council of WA, so we have not diversified into those areas because there's such good service there supplied by NCWA. Our main brief and the main focus of the nurse specialist service is that we visit clients in their home. And that has been our practice until the emergence of COVID. And as we're all faced with the same challenges, it's becoming difficult. As of yesterday, we have ceased face-to-face visiting. Simply because our cohort are vulnerable, and we're not wanting to go like the angel of doom from house to house, exposing people. So as of yesterday, we are now using Health Direct for our visits, but it is business as usual. Our main focus is, when we're with a patient, is education, assessment, and reporting. And one of the delights of our service is that people are never discharged, but we do provide ongoing support from diagnosis to palliative care. Having said that, because of the large patient load, and I point out that the average patient load for a metropolitan nurse is probably 350, we stopped last year doing 6 monthly review visits as a matter of course, and we've now gone to please ring us if you need to be in touch, and we will certainly be able to fit you in much quicker. So that enables us to see new referrals into the service without so much of a wait period. So it's worked out quite well, and it empowers the patient too, that they will be the one to initiate a visit. Having said that, the beginning of every calendar year, we do a telephone review to everyone who has not been seen in that year. So it's working quite well. And again, it's the ways we've had to accommodate our increased patient load. So we've got an open referral system. The only criteria that we had to introduce is that the patient must have a firm medical diagnosis. So not a telephone call from the wife who thinks her husband may have Parkinson's. So a firm medical diagnosis, not necessarily by a neurologist, but a GP, neurologist, physician. So the open referral system means that a person can self-refer. A lot of our referrals come from neurologists and geriatricians, and we also welcome referrals from yourselves, from health professionals. As a result of the last session we did like this, we have introduced a health professional referral form, which is available on our website, and there's the link there. But if you just go to our website and go to your health professional page, you'll see it. It's worked out beautifully because you get to write as much information as you want. And I do find that physios and OTs are so good at giving us information. So please use it, and it's worked out very clear. And if you have any suggestions for improvement, we'd love to hear those. It's been wonderful. It saves you time and it saves us time. So who do we look after? As Lisa has already described, Parkinson's just is not just limited to idiopathic Parkinson's disease. So we look after people with idiopathic Parkinson's, and we also look after those atypical Parkinsonism patients that Lisa described. So progressive supernuclear palsy, multisystem atrophy, and corticobasal degeneration is another one that we do take care of. We are inclined to see those people perhaps more regularly than the idiopathic Parkinson's because their progression is quicker, and we can try and troubleshoot earlier, predict what the next tool in the toolbox is going to be for those patients. So we're very mindful of those. And one of the other benefits of being a small specialized team is that these are rare conditions, but the more we see of them, the more informed we are. And that helps the patient in turn with education about their condition, which they often feel no one knows anything about. So those are all the conditions under our management. I'd like to point out, we try not to see Lewy body dementia. Their needs are much better met by Alzheimer's WA or Dementia Australia, because respite is really what they need more than the nursing service that we offer. So what do we do? As Lisa said, with her assessment, it's very person-centered. We are nurses with expertise in these conditions. We do not pretend to be physios or occupational therapists. So we do a nursing assessment of the home environment. And often we are the first people in that home. And way back in the early days, we were definitely the first people in that home. So the environments and the hazards that we unearthed have been amazing, to say the least. So we can then, in our report, highlight the person that we are referring the person to. So say the OT department or the physio, of the potential problems. A little bit of forward knowledge is always helpful. And we do work as a team with all you other guys. We also do objective assessments of mood and of cognition. We carry out the MOCA and we do the geriatric depression scale. As nurses, a lot of what we do is evaluate the patient's medications, look at adherence, look at compliance, because sometimes it's adherence, which is a problem with Parkinson's. They're not likely to be non-compliant and not take their medication. They can be quite creative and over self-medicate. So we get the medications out on the kitchen table and look at what doctor has prescribed, but tell me, what are you really taking and how long is it lasting? So we have a very in-depth patient level conversation about medications. And then we refer to required and appropriate services. And that's the joy of being specialized, is we know who the other players are in the Parkinson's field, and we refer patients to the right services. And our aim, this is a very short, snappy overview of Parkinson's, but the whole aim of Parkinson's WA is to support the WA Parkinson's population and the carers and wives and families. So thank you.
Thank you, Janet. I'll get you to stop sharing so I can share my screen. We were going to take questions, but we're running out of time, so we're going to we're going to skip through that. I'm just going to conclude the webinar. Our upcoming trainings and events, please register if you are interested in registering. It is on our website, so just click through to our website if you want to keep track of any upcoming ones. Our Remove Hazards campaign is starting from the 1st of March to the 30th of May. If you want to be involved, there's a campaign toolkit that you can download. I highly recommend downloading that. There's a heap of resources, including how to get up off the floor, which might be a useful resource that you can recommend to your patients and clients. And then lastly, just if you want to get involved and be part of our Community Falls network, which is a network that meets quarterly, and they're full of health professionals that work in the falls prevention space, you're welcome to be involved in that. Just send me an email. And then there's Connected, which is a networking platform for health professionals. People get paired monthly, bi-monthly to another health professional that works in the injury prevention space. So you can use a QR code on the screen there. And when you close this webinar, there will be a survey that pops up. We'd love to hear your feedback regarding today's webinar. So please do send us some feedback if you do have any. And that is it for today. Thank you so much. I know we ran out of time there and I tried to rush through, but thank you all so much for your time, and thank you all for the speakers for taking your time out of your evenings to be involved in this. So all the resources will be sent to everyone. So yeah, rest assured you will not be missing out on anything. Thank you so much. I'm just going to end it now.
Thanks, Apu.
Thanks, Apu. Thanks, everyone.
Thank you. Bye.